I'd like to welcome all of you in this grand round. It is my pleasure to introduce the speaker of this grand round, Dr. Hatem Kalantan. He is Associate Medical Director. Dr. Hatem is Associate Professor and Consultant Ophthalmologist. He is a member of the Anterior Segment Unit, Department of Cardiology, College of Medicine, King Saud University. He will speak today about the hemostatic screening before cataract surgery. Is it necessary, Dr. Hatem?
Thank you, Prof. Hani. First of all, I would like to congratulate you all by the Foundation Day and celebrating 3 centuries from the start of our nation. So what we will be talking about today is hemostatic screening before cataract surgery and whether or not this is necessary. So to start with, cataract surgery, as you all know, is a highly cost-effective means of vision restoration, and approximately 10 million surgeries are performed worldwide every year. Cataract surgery is simple. It doesn't require general anesthesia and doesn't typically cause blood loss or hemodynamic challenges in comparison to other major surgeries. And the complication, if they may arise, they are generally limited to the eye itself. And usually it is done under ambulatory care as an outpatient setting. And if there was unplanned hospital admission, it was estimated to be about 0.05%. In general, why we are doing the preoperative testing, we do this with the hope of identifying potential unforeseen issues that might lead to complication from surgery. And it is likely that this preoperative medical testing will detect medical condition, but it is questionable whether this condition should preclude these individuals from cataract surgery or change their perioperative management. We will discuss the impact of preoperative hemostatic testing on ocular bleeding complications. So let's start with a case. If suppose you have a 6-year-old patient, medically free, he came today for his scheduled phacoemulsification. You are in the operating room, but you discover that he didn't do the coagulation profile. So what will be your decision? It's either you will be conservative and cancel and reschedule him, or you can go ahead with the surgery. So which decision is the correct one? Let's go through some information and see which one to choose. So to start with, when deciding the patient for surgery, we take history from him, medical history. This should include the bleeding history, and the bleeding history as in easy bleeding and prolonged bleeding. It doesn't stop quickly, or easy bruising. And this actually can be challenging in patients with mild bleeding disorder, as their symptom might overlap with normal individuals. And of course, we have to ask about bleeding disorder like hemophilia, but this at the age of cataract surgery, it should be established as a diagnosis since childhood. Liver disease, family history is important of bleeding tendency, and also we'll have to review medication that might affect hemostasis like antiplatelets or anticoagulant. It was developed in the past some questionnaire which called the bleeding assessment tool. The objective is to quantify the bleeding symptoms in a standardized manner. It has certain question, and there will be giving a score for each symptom, and we can predict with a good accuracy how much this patient is risky to bleed. Also, beside the pre-operative assessment, you usually have the patient coming in a day or two before to be seen by the anesthesiologist and the internist. And Boston Medical Center identified the cost of the frequent visit for the patient and the troublesome of patients coming and going, especially for elderly. So they had an initiative obtaining history and giving preoperative instructions by phone to determine if it could safely substitute for a standard in-person history and physical examination in patients undergoing cataract surgery. And they have 2,055 patients underwent phone visits and 2,911 patients who underwent the visiting standard history and physical examination. There were no unplanned admissions and no mortalities within 30 days following the surgery of all the patients, but they discovered that the same day surgery cancellation were significantly lower 2 years after the initiation of this process. So in 2015, they had 1,001 cancellation, and it decreased to 75 in 2016, and 2017 it was 49. So after the history and conducting some exam, mostly by the internist and anesthesiologist, we will go ahead to order some lab tests. For the bleeding, we have to understand certain physiology that it is compromised by the 4 compartments: vasculature, platelet, coagulation, and fibrinolytic system. And there is no global hemostatic test that can capture the complex interaction that exists in vivo between these 4 compartments. So let's have a look at the coagulation cascade. We have the intrinsic pathway and we have the extrinsic pathway. The intrinsic pathway starting with factor 12, then it is changing the factor 11 to active factor 11, and the factor 9 to active factor 9, factor 5 to active factor 5, and the active factor 5 is the common pathway between the intrinsic and extrinsic pathway. The extrinsic is starting with the 7, which is the tissue factor, and forming also the factor 10 to active factor 10. Factor 10 with the factor 5, changing the prothrombin to thrombin, fibrinogen, then change to fibrin to stop the bleeding. So what are the tests that commonly ordered for monitoring the bleeding? We have the prothrombin time, which is used to evaluate the extrinsic pathway of coagulation, which consists of tissue factor and factor number 7. We have the PTT, or activated partial thromboplastin time, which is used to evaluate the integrity of the intrinsic coagulation pathway, the prekallikrein high molecular weight kininogen factors 12, 10, 9, and 8. In the literature, there is no evidence that they have any value in predicting operative bleeding in a patient with no history of bleeding or liver disease. And also, on the other hand, interestingly, some other disorders, bleeding disorders, such as von Willebrand disease, may not be detected by this routine PT and PTT. Factor 12 deficiency and lupus anticoagulant, which is known to reveal higher PTT, so it will show as an abnormal, but we know that it is clinically irrelevant and it is not associated usually with bleeding. On the other hand, PT and PTT are insensitive to clinically important bleeding disorders with normal PTT, like mild von Willebrand disease, hemophilia A, factor 13, and alpha-2 angioplasmin deficiency. There was a meta-analysis that showed clearly that even when the PTT and PT are abnormal, they don't necessarily predict increased risk of bleeding. Other limitation of what we usually do, the PT and PTT, the PT results from different laboratories are not comparable. we have to do something with calibration system that compare PT results to the World Health Organization standard, expressed as international normalized ratio, and between different lab it is different, so we have to standardize it. However, the INR is only valid for patient stabilized on vitamin K antagonist. This means that they are neither reliable nor reproducible for patients with prolonged prothrombin time for other reasons like liver disease or disseminated intravascular coagulation and congenital factor deficiency. And the accurate range of the INR is only for values within 1.5 to 4.5 range. Below or above that, it is usually not accurate. Other limitation is that no such standardization exists for the PTT, resulting in marked variation in the sensitivity of different reagents to coagulation factor deficiency and inhibitors. The PTT also is generally not sensitive to low molecular weight heparin patient administration. PT and PTT were designed as diagnostic, not a screening tool to confirm the clinical suspicion of bleeding. So if the patient is having by history and examination or family history, he has a bleeding tendency, we can confirm that by the PT and PTT. And this is actually different from their use as screening test in otherwise healthy population. In the preoperative patient, we tend to prescribe routinely PT, PTT, whether this patient has bleeding tendency or not, or he doesn't have a family history, we just order this. And prevalence of bleeding disorder is extremely low, and the chances of detecting something by doing all these tests is also low. This is combined with the cost for this and whether or not this is a cost effective or not. Even where the tests are normal, there is a great chance that this can result from false positive. So we need to repeat the test to make sure that it is really high, it is not just a false positive, or detection of disorder that is not associated with bleeding, like, for example, the factor 12 deficiency and lupus anticoagulant, which have relatively high prevalence in the otherwise normal population. So these disease entity having abnormal tests, but they don't actually predispose the patient to abnormal bleeding. And the false positive results can potentially lead to unnecessary further investigation and generate delay, anxiety of the patient, and further cost of visiting and harm. And interestingly, 30 to 95% of abnormal results from the screening test are either not documented or followed up. So many of the doctors just order this or has this their order in their favorite list and just order it, and sometimes 30 to up to 95% they don't bother to look at them, that potentially increasing the risk of litigation. So if they didn't do it, it is better than doing it and not reviewing it. So when it comes to surgery, the patient is coming for surgery, for cataract surgery, and we have decided beforehand that which technique of anesthesia will be administering to the patient, topical or retrobulbar, peribulbar, or subtenon. So in topical, you might not have this subconjunctival hemorrhage that can be associated with peri and retrobulbar, but for patients with really having bleeding tendency, even with topical, even if you touch the eye to fixate the globe, it can bleed, and I have patients that having 360 subconjunctival hemorrhage from just touching the conjunctiva during topical anesthesia. So what about peribulbar hemorrhage that is caused by the anesthesia. So this peribulbar hemorrhage, obviously, it will not be caused by topical anesthesia, but it can happen with peribulbar, retrobulbar, and subtenon. The incidence of peribulbar hemorrhage that sometimes can be serious. It ranges between 0.03% and 1.7%. It has been reported. The higher the sample size, the lower the percentage. So 0.03%, it's really very low percentage of incidence. In an observational non-randomized study involving over 19,000 patients for cataract surgery, the use of aspirin warfarin were studied. It showed similar but low rates of serious bleeding complication in both groups. The group that is using aspirin and warfarin and the other group that is not using aspirin and warfarin, who continued to within 14 days of surgery or stopped the aspirin before 14 days before the surgery. So in both groups, it was about 0.06%, which is really very, very low. So what about the surgery technique and expectation of bleeding? Of course, for the all the extracapsular cataract extraction, we are touching a vascularized tissue, which is conjunctiva and incised and scleral tissue. So chances of bleeding, even with later on bleeding in the surgery, subconjunctival hemorrhage or suprachoroidal hemorrhage is more with extracapsular cataract extraction. But with effect emulsification, and if we did a clear corneal incision in which we go through avascular cornea, the bleeding that can happen is minimal to none. And as you know that for combined surgery, if we combine cataract extraction with any other surgery, like glaucoma surgery or retinal surgery whatsoever, the risk of also suprachoroidal hemorrhage increase. This is either due to prolonged the surgery or having hypotony during some stages of the surgery. So we can have also postoperatively a hyphema, and this hyphema can be difficult to clear, and it might stain the cornea. So for patients who are having risk of that, we have to consider that and keep that in mind. Vitreous and retinal hemorrhage also can happen if there is a bleeding tendency for the patient or the patient is on anticoagulant, but the impact of that usually is not as disastrous as the suprachoroidal hemorrhage. Suprachoroidal hemorrhage, which is the expulsive hemorrhage, which is our nightmare. And fortunately, until now, I didn't have my first case, but we have to be prepared for that, and we have to take all the measures that can minimize the incidence of that. In a study that is done by Benzimra, he reviewed data of 55,567 surgeries, and he found that no increased suprachoroidal hemorrhage risk among the blood thinning medication users. So whether or not this patient is using anticoagulant or antiplatelet, it doesn't matter on the incidence of the suprachoroidal hemorrhage. It will happen anyway, if the patient is having or not. On the other hand, some other study, this study actually didn't have the total number of patients, but they studied the patient that had the suprachoroidal hemorrhage, which they count to have 108 cases of suprachoroidal hemorrhage, and they compared them with 449 controls, and they found a statistically significant relation with bleeding diathesis. So if the patient is having a bleeding disorder, they found that it is more if the patient is having bleeding disorder, and the difference was statistically significant. And on the other hand, the relation was not that significant with the use of aspirin and warfarin. So one study was one study was against the having suprachoroidal hemorrhage as a as a consequence of risk factor by bleeding disorder. So let's review the cataract surgery in certain bleeding disorders. You have the factor 11 deficiency. It's a bleeding disorder, also known as the hemophilia C. And before surgery, for other than the ocular surgery, they usually need the fresh frozen plasma to neutralize the bleeding tendency and having less complication of bleeding. And all the reports, they describe the successful cataract surgery after prophylactic fresh frozen plasma, and they copied from other surgeries and having this report, and they administer fresh frozen plasma, and they didn't have bleeding afterwards. The severe factor 11 deficiency is associated with also a significant increase in the risk of bleeding when the surgery involves the sites that increase fibrolytic activity. The risk is lower when tissue sites free of fibrinolytic activity, like the circumcision, appendectomy, orthopedic surgery, and cesarean section. After that, it came several case reports that were published supporting the prophylactic treatment by fresh frozen plasma or antifibrinolytic agents such as aminocaproic acid or factor 7 activated, followed by continuous infusion, similar to what's recommended for patients with severe hemophilia A. All of these reports, they use the fresh frozen plasma before the surgery and didn't have any perioperative bleeding. But then came a case series that was performed by Fabian. They operated 7 patients. They have severe factor 11 deficiency, but they didn't use the prophylactic fresh frozen plasma. And their rationale that this is not needed as other type of specific surgery like the circumcision. So they did the surgeries without the fresh frozen plasma, and all the surgeries were through clear corneal phacoemulsification under topical anesthesia. So if it is a scleral tunnel, we would expect bleeding. If it is peribulbar or retrobulbar, we would expect bleeding, but they did it under topical anesthesia and clear corneal phacoemulsification. And they found neither major nor minor bleeding events were observed in any of the operated eyes during surgery and follow-up. What about hemophilia A and B? I found a study that reviewed 19 cataract surgery of 14 patients. They diagnosed with hemophilia A or B. One patient had postoperative bleeding out of the 19 surgery they performed in the form of subconjunctival hemorrhage 1 day after the procedure. And this procedure was in the past, and it was done by retrobulbar block. And when they found it the first day, they gave the patient activated prothrombin complex concentrates for 5 days, and the bleeding stopped and didn't progress more. Authors of this study, they didn't recommend clotting factor correction with topical or subtenon anesthesia in mild patients with factor 8 or factor 9 levels. So if it is not severe, so they didn't recommend doing the clotting factor, but they recommended to correct the clotting factor deficiency if the local anesthesia is planned, peribulbar or retrobulbar, aiming at a factor level between 0.8 and 1 international unit per milliliter, and trough level of 0.15 international unit per milliliter for 24 hours regarding of hemophilia severity. So if it is planned for local anesthesia, they advocate the use of clotting factor, and when it reaches certain level, the patient is more safe to proceed with the surgery. Thrombocytopenia is a low platelet that could be due to various reasons, and some drug like antifibrinolytic, aminocaproic acid, or tranexamic acid that's often used by ophthalmologists to treat hyphema were found to be associated with the presence of dense fibrin after cataract surgery when administered to a thrombocytopenic patient. So this is an important point to keep in mind. This study that reveals that there will be some fibrin formation if we use aminocaproic acid in patients with thrombocytopenia. There is a study that wasn't done on ophthalmic surgery, but it had gathered a lot of patients, 2,078 cases. 77 of them were identified to have abnormal coagulation result, which was 3.7% of the total patient. Postoperative bleeding occurred in only 3 cases out of this 77. 2 cases due to surgical procedure, and it didn't have anything to do with the bleeding, with normal preoperative testing. So the tests were normal, though the patient had perioperative bleeding. 1 case only, he had hemophilia A, and they discovered that this hemophilia A wasn't screening even before the surgery, and they were surprised to have the bleeding, and he was diagnosed afterward with hemophilia A. They concluded that routine coagulation screening before surgery or invasive procedures to predict perioperative bleeding in unselected patients is not recommended. They recommend to select patients based on physical examination, type of surgery, which is important. Would you expect bleeding or not from the surgery? Family bleeding history, and concomitant use of antiplatelet and antithrombotic activity. These are the distribution of their cases. They're 2,078, and only 77 from them with abnormal screening. And just to keep in mind that when they repeated the test, 15 out of these 77, they turn out to be normal after repeating testing. So don't decide finally with the initial testing. Always repeat the test to make sure that it is not false positive. And this is the patient among the 61 without preoperative screening. 1 patient had postoperative bleeding, and later on he was discovered to have hemophilia A. So let's go to what about the cataract surgery on patients using anticoagulant and antiplatelet. So this is a significant percentage of patients. They are using the anticoagulant and antiplatelet. So what should we do? Should we stop this? Should we bridge it with heparin, or we can continue the medication and proceed with the surgery? Let's see. Millions of patients receive long-term anticoagulant and antiplatelet medication for prevention of venous thromboembolism, atrial fibrillation, valvular heart disease, and stroke. And if we stop this medication for the purpose of surgery, there will be a risk of thromboembolic event that can affect the total overall health of the patient. We are ophthalmologists. We usually concentrate on the eye, but we have to remember that to take this patient and consider him as a whole. So what if we stop his medication? What will happen to his thromboembolic event? Will be having increased risk of thromboembolic event. On the other hand, continuation of the therapy may be associated with bleeding. So there is always a balance you will have to keep in mind and consider whenever you decide to stop or not the antiplatelet or anticoagulant. Sometimes we go ahead with the bridging, and we just stop the anticoagulant and bridge it with heparin, low molecular weight heparin, and then resume it after the surgery. But even this technique was not the effect of that in preventing the thromboembolism is not well established. So Kobayashi, he studied 558 eyes It's corresponding to 355 patients who underwent phacoemulsification surgery. They compared two groups. The first group was on warfarin and aspirin for at least 6 months. Both groups were. And before the cataract extraction, they discontinued the pharmacotherapy 1 week and resumed it 2 days after the surgery. The other group, they didn't discontinue, they just continued their blood thinners and went ahead with the surgery. They noticed that for the subconjunctival hemorrhage, there was increased risk for the patient that on the continuation group. It was about 1.6 times the times of the patient that didn't discontinue this medication. Regarding the incidence of intraoperative and postoperative complication and visual outcome, there was no significant difference that was reported between these two groups, the group who discontinued and the group who didn't discontinue and continued. The outcome was the same. Another study by Benzimra, he reviewed a lot of patients for the UK Cataract National Database Registry. They compared here the operated patients that are taking anticoagulant and antiplatelet. On the other arm, the individual who are not taking anything. So these are two different groups. The first study was comparing both taking, one group discontinued, one group continued. Here they compared who is taking with who is not taking. The risk of subconjunctival hemorrhage was again higher in the patient taking anticoagulant. It was 1.46 times with significant p-value in the patient who were taking anticoagulant or antiplatelet. Another study by Baraké, they did a prospective non-randomized interventional case series where they studied 75 eyes corresponding to 63 consecutive patients under treatment with comedine therapy at the time of cataract surgery. And 9 of these patients were also using antiplatelet medication. 6.3% of patients had minor postoperative ocular hemorrhage with no significant intraoperative bleeding that affect the visual outcome. All hemorrhage resolved within 1 week without affecting the visual acuity. He also in another study reported a case series of 51 eyes corresponding to 40 patients. They concluded that in patients with simple cataract at high risk for thromboembolic complication, phacoemulsification surgery with IOL implantation using clear corneal incision under topical needle-free anesthesia was safely performed without discontinuation. So all the studies, they are continuing the medication without any significant bleeding events. Another study was Salam and Renz. They published a case series of 16 patients. There was a 25% risk of subconjunctival hemorrhage following subtenon anesthesia, but there were no intraocular or postoperative complications associated with continued Plavix or clopidogrel gel used in the intraocular surgery. So what about the societies? What do they recommend to stop or to continue the anticoagulation for the purpose of surgery? The American College of Chest Physician in 2008, they developed an evidence-based practice guidelines for antithrombotic therapy during the perioperative period. They recommended that patients should be kept on anticoagulant therapy for minor dental, skin, or eye procedure. So they are chest physicians, but they are recommending for us to continue. In contrast, high-risk patients or those undergoing surgery for which there is increased risk of hemorrhage should be treated with bridging therapy involving subcutaneous low molecular weight heparin. So to go with their recommendation or not, their specialty is away from our specialty, and actually they cannot make a recommendation for our surgeries. What about the American Academy of Ophthalmology? They have stated that anticoagulation with warfarin doesn't significantly increase the risk of choroidal hemorrhage, but they didn't have anywhere any particular recommendation in this subject. About the Royal College of Ophthalmologists of the United Kingdom, they recommend the international normalized ratio INR should be checked to ensure the patient is in the desired therapeutic range. With needed local anesthesia, the risk of orbital hemorrhage is increased from 0.2 to 1%, which is 5-fold. So they are in the conservative side. They advocate for having INR, especially for needed local anesthesia. Consideration should be given to use of topical anesthesia or subtenon block rather than Peribulbar or Retrobulbar. Canadian Ophthalmological Society, they didn't find evidence to suggest that patients who continue the use of aspirin and warfarin were at increased risk of ocular hemorrhage, similar to the conclusion of the previous studies. It is recommended that preoperative INR done, so this is the same as the Royal College of Ophthalmologists, should be in the therapeutic range if injection anesthesia is contemplated for a combined procedure. So they keep repeating that if you are putting a needle in the orbit, you have to be cautious with these parameters, the INR and the other lab tests. So, except for special complicated case in which, for example, you are expecting a suture fixation of an IOL that is planned or maybe required, the risk-benefit analysis support the continuation of the antiplatelet and anticoagulant medication for patients undergoing cataract surgery. So after that, will this information and the study results change the practice? Also, the research evidence is available. Not all the time it directly follows that the practice will change. American Academy of Ophthalmology, they prefer practice guidelines, recommend testing on indication rather than routine preoperative medical testing. So in their 2016 guidelines, they didn't recommend that testing everybody for everything. They recommend that we just screen the patient and know which test to order. But on the other hand, the Center for Medicare and Medicaid Service in the States, which cover the majority of cataract surgery in the USA, it currently covers the preoperative service that assess the beneficiary fitness for the surgery. So as a physician, if I found this is covered, so I will order whether or not I believe that it is needed or not. And despite the endorsement of no routine testing prior to cataract surgery by professional society and practice guidelines, the performance of preoperative medical testing in patients undergoing cataract surgery has not diminished. So there are some other driving factors for this practice, and the evidence is not always followed. There are other factors that control the practice of the physician. Among these factors are regulations, regulation of the facility or the country or the whatever authority. It can have the upper hand in that and drive the physician to order or not the tests. Enriched habits of practice, and this is something you have to have an effort to change, because all your life you are used to do something, and then you have to change it. It will take effort from the physician himself, from the facility, and from all of the community. Defensive medicine for patients that are afraid of medical litigations and the lawsuits. They are over ordering everything in anticipation that this might protect them from litigation and medical. Economic incentive is another issue. If the physician is being paid for ordering this test and no rejection is happening, he would order it. So all of these factors actually play a role to change the practice of the physician. So in order to change the behavior, there will be a need to be a consensus of research evidence across more than one medical specialty. So not only the eye, they have to see other specialty, and there will should be a consensus and agreement between all these specialties that this is the right thing to do. And also, there should be incentives to change the policy at institutions and at individual practice. This is maybe the only way or the hard way to get the practice changed. So what about other specialties in neurosurgery? In patients undergoing neurosurgical procedures, coagulation studies had little power to predict bleeding complication for these high-risk patients. They found that the bleeding history was more predictive of bleeding complication. This is the point that emphasized over and over, that history is the main cornerstone of bleeding tendency, and it can guide the further lab results and anticipate the perioperative bleeding. So it was more predictive of bleeding complication and had higher sensitivity for predicting those operative outcome and than did the routine blood tests. So history guides the blood test. We don't do blood tests for everyone. They calculated that doing away with this testing before neurosurgery procedure would save more than $81 million annually in the United States alone. So this is an important point that they are highlighting. So when they are touching on the money buttons, the policies and procedure will be changed faster. What about the dental? Regulation for preoperative evaluation seems to be very unpredictable by the type of the procedure and venue of care that will be determined of patient risk and safety. Risk of many dental procedures are equal or greater than us in the cataract surgery and the clear corneal phacoemulsification. Yet, elderly patients undergoing most dental procedures, they don't routinely undergo separate preoperative history and examination, even if minimal sedation is anticipated. Even with harsher procedure like colonoscopy, the routine colonoscopy is typically performed under monitored anesthesia care with a depth of anesthesia greater than for cataract surgery, but preoperative competitive medical evaluations are not routinely performed. And the reason for that, the dental and colonoscopy, they didn't have this requirement to proceed with the surgery. The reason might be historical, getting back to many decades when cataract surgery was more than 1 hour long procedure, and the patient has to be admitted, and then post-operatively, the patient had to be put on bed rest as inpatient for a week or so, where they were at risk of thrombosis, embolism, and other serious medical events. And maybe we are carrying this habit and ordering this. So the cataract surgery nowadays is done as an outpatient procedure without the need of general anesthesia and without even the need for all these preoperative tests. So let's talk about money now. The cost of preoperative screening and how much does it cost, and is it really cost effective or not? So in the States, cataract surgery is the most commonly performed elective operation for Medicare beneficiaries in the United States. And it was estimated in the United States for preoperative testing before 2000 that have suggested more than $150 million yearly was spent on this preoperative testing. And the cost, in another survey, they calculated that the cost associated with routine preoperative medical testing is 2.55 higher compared to selective medical testing. So they have two groups, group with all the tests and group with selective tests, and they found that the expenditure for this patient that is having all the tests done, it is 2.55 times higher than the other one. And a report, combined rate of cancellation or postponing of surgery specifically for medical reason was a little over 2% of total surgery, irrespective of doing the complete or the selective testing. So it is basically the same. This is one of the reports that reported more than 500 patients having routine testing, and another 500 patients with no testing, and they just delineate what is the complications that arise. And when we see here that the only complication they reported, which is the vitreous hemorrhage as a bleeding complication, was one in each group. So there was there was much difference between the group of testing or not testing. So unnecessary testing, it can lead to unnecessary postponement or delay of the surgery. And if we delay the cataract surgery, the patient will not be able to regain his vision to a better level, and there will be risk of physical injury, and also hip fracture is increasing. So the lifestyle of the patient, we are just postponing him for unnecessary reasons. Continued independent living and general quality of life are reduced in patients with unoperated cataract. So this delay, sometimes they are not be justified, and we have to go ahead with the surgery. Surveys also have shown that the majority of clinicians involved in ordering this range of pre-surgical medical tests, they don't believe that they are necessary, but they are ordering anyway because of the reason I just mentioned. And another interesting study, a survey was conducted between ophthalmologists, anesthesiologists, and internists, and they found out that each group of that physician, they believe that there is little value for such testing, but they believe that the other physician, he needs this test, so that's why he's ordering it. It's not about the belief that this test is needed. It is a belief that the other physician might need it in order to clear the patient for surgery, and they don't want their surgery to be canceled, so they order whatever it is needed, whether or not they are convinced or satisfied that this will add to the benefit of the patient. So most of the reviews suggested that preoperative medical testing for cataract surgery doesn't protect against medical adverse events. So these adverse effects, if it is going to happen, it will happen whether or not you did the preoperative medical testing or not. So in conclusion, most of the patients going for cataract surgery, they don't need routine coagulation studies. The test should be ordered for specific patients, and this should be strictly guided by history. Avoiding unnecessary testing, it can save a lot of healthcare resources and expenditure. Cataract surgery can be performed safely in patients taking both anticoagulant and antiplatelet drug with topical anesthesia when it is administered, and surgery is performed through clear corneal by a skilled surgeon. And this will prevent unnecessary postponing of cataract surgery that can significantly improve the lifestyle of the patient. In some complicated scenarios, such as small pupil in which you are anticipating to use iris sockets, for example, or floppy iris syndrome, iris neovascularization, in which you might touch the iris and having bleeding significant to the exfoliation or techogenesis, there might be an increased risk of intraocular hemorrhage. So we should keep that in mind and order the blood investigation for them. Management should be individualized, and the decision to interrupt antiplatelet or anticoagulant therapy should be considered in consultation with the patient, internist, and or cardiologist. Thank you.
Thank you, Dr. Hatem, for a comprehensive and very informative lecture. I would like to open the floor for the question. If you have any question, please.
All in vacation with the foundation day.
Any question?
So there is a question in the chat that is there any study that looked for other factors along the antiplatelet anticoagulant usage, like hypertension and their risk of bleeding? I didn't go in depth of, about what is the risk for hypertensive patients for bleeding, but hypertension can be an independent risk factor for bleeding, and it is known that suprachoroidal hemorrhage is increased by the presence of hypertension. So if the patient is having hypertension, especially if it is uncontrolled, you might think that you don't want to add more bleeding risk to him, and you can go ahead and do a screening lab test for him. Okay, Dr. Faisal Qahtani.
Assalamu alaikum wa rahmatullah. Thank you very much, Dr. Hatem, for very important topic and practical. Just want to ask you, the studies done on phaco did not look at, if it's done on with a peribulbar or retropulbar block, because it was not clear for me if that was done or did not look at.
The consensus, all the studies that reach that if you are doing phacoemulsification through clear corneal approach, not scleral approach, and with the use of topical anesthesia, you don't need a bleeding screening for these patients. But if you are using anesthesia, as in a local anesthesia, you have to individualize the case and decide whether or not you want to order the bleeding test lab.
Yeah, but it was not mentioned in specification on those patients done with stopping their anticoagulant against those without.
In one study, they showed that there was no difference between the two groups that stopped or not in regard to significant intraocular bleeding that caused change in the visual outcome. So there was no difference between the two, that's stopping and non-stopping. There was a difference in the subconjunctival hemorrhage if they are doing local anesthesia. For example, one of the studies showed that 1.6 times higher, and the other study 1.4 times higher from between these who stopped and who didn't stop. But for the significant bleeding, there was no difference.
Thank you. I know it would be very good to have, because topical, yes, usually we don't, but I feel, afraid to give a retrobulbar or peribulbar if I don't stop the anticoagulant or antiplatelet medication?
Yes, I agree.
Thank you.
Okay. So, Mohammed Abu Saif for earlier raising his hand. Are you still there, Mohammed?
Assalamu alaikum.
Assalamu alaikum.
Dr. Hatem. And my question was similar to Dr. Faisal Al-Qahtani question. That let's say that you decided to go ahead and block the patient with a subtenon injection. The risk of bleeding would be the same if we stop the anticoagulant medication. You already touch on this.
So, for example, if you didn't stop the medication and during the surgery you found the patient that is restless and you have to give the injection, there will be a risk of bleeding if he has a bleeding tendency. But if, for example, you are in the clinic and you saw a soft cataract and the patient appears to be cooperative and you will be confident that you will continue this as a topical anesthesia, no need for screening.
Thank you.
Dr. Saad Al-Harbi is asking, what about screening for other diseases like anemia? Anemia didn't have come through specifically for cataract and their bleeding. So for the short answer is I don't know the answer whether or not the screening for anemia is cost effective and whether or not it should be done on every patient, and does it justify doing it for every patient in anticipation of bleeding. So if anyone has experience in the effect of anemia on bleeding tendency, just go ahead, please. Okay. There is no other questions. Then we can conclude here. And I think we can have a 5 minutes before the quiz for the residents. Will that be good?